ኖ
ይታያል።
አዎ ይታየኛል ዶክተር። ስላይድ ሾው ላይ ማድረግ ይችላሉ?
እ፣
ጥሩ።
አዎ፣ ልሞክር። ዩ አር ስክሪን ሼሪንግ ይለኛል።
አዎ ልክ ኖት። ስላይዶ እየታየን ነው አሁን። እስቲ ወደ ኔክስት ስላይድ እያደረጉ ማየት እንችላለን?
ስ
አዎ አዎ፣ ቴንክ ዩ። ልክ ነው።
አሁን ጥሩ ነው።
አዎ ጥሩ ነው። ቴንክ ዩ።
ድምፄስ ጥሩ ነው?
አዎ ድምፆትም ይሰማል፣ ቪዲዮውም
አዎ
በደንብ ይታያል።
በጣም ጥሩ ነው። ስለዚህ ባለው ወይ እንትን ምንድን ነው ኮኔክሽን እንሞክራለና።
ያው ይቻላል ዶክተር። አዎ
ቴንክ ሶ ማች።
እሺ፣ ቴንክ ዩ።
አሁን ስቶፕ ሼሪንግ ልበለው።
አዎ ይችላሉ። ትንሽ 5 ሞር ሚኒትስ ተጨማሪ አቴንዶች እስኪገቡ እንጠብቅና
በቃ
ከዛ
ጥሩ።
በኋላ መጀመር እንችላለን።
ድምፄ ይሰማል? ይሰማል ድምፄ?
የስ አዎ ይሰማል።
እሺ እንጀምራለን። አሁን ሰዓቱ ስለደረሰ ዌልካም ቱ ኢትዮጵያ ሜዲካል አሶሲዬሽን ፕሪ ኮንፈረንስ ሲኤምኢ ሲሪስ። ማይ ኔም ኢዝ ሙሉጌታ በላቸው, ኢማ ሜምበርሺፕ ኤንድ ሲፒዲ ኮኦርዲኔተር. I'm here to introduce today CME session and the moderator of the session. This is the last but not the least pre-conference CME session, and its title is Digital Technology in Medicine with a special emphasis on surgery. The moderator of this session is Dr. Abraham Gebrexiabier, and it's my honor to introduce him. Dr. Abraham Gebrexiabier is a medical doctor specialized in general surgery, subspecialty in plastic and reconstructive surgery. Dr. Abraham is a distinguished senior plastic and reconstructive surgeon with over 30 years of medical practice, and his medical journey began in Ethiopia, where he earned his medical doctorate from Addis Ababa University in 1991. After serving as a general practitioner at Negele Borana Hospital, he completed his specialization in general surgery at Addis Ababa University in 1998 and worked as a general surgeon at Minilik at Metu Karl Hospital, building a strong foundation in comprehensive surgical care. Driven by a passion for restoring surgery, he paused a subspecialty in plastic reconstructive surgery through an international fellowship at Auckland University, Norway, Christian Medical College, Vellore, India, and Addis Ababa University, completing it in 2007. He further enhanced his skills with specialized certificates in hand surgery, CMC Vellore, and traumatology, Munich. Since 2007, Dr. Abraham has been based at the Alert Center in Ethiopia, where he currently serves as head of the plastic and hand surgery unit and physician in charge of cleft care. Since 2016, he has been serving as an associate professor at Addis Ababa University. He is an author and co-author of numerous international studies published in leading journals, including the Lancet, British Journal of Surgery, Anesthesia and Plastic and Reconstructive Surgery, Global Open. His contributions have been recognized with multiple honors, including the prestigious Lifetime Achievement Award in 2022 and a Smile Train Award for Excellence in Cleft Care in 2025. He is an active member of IMA, Surgical Society of Ethiopia, COSEXA, ACS, and the Pan-African Plastic Surgery Association, among others. Dear Dr. Abraham, now the floor is yours to proceed, please.
Dr.
Are you
Abraham is
speaking,
muted.
Dr. Abraham?
Okay. Hello? Can you hear me?
Yeah, you can continue.
Thank you very much for the chance to be able to introduce and moderate a famous person that is a long time colleague and brother of mine, Dr. Ataklty Baraki, who is a consultant plastic reconstructive and general surgeon at Alert Addis Ababa University College of Health Science, Alert Comprehensive Specialized Hospital. Dr. Ataklty has been in medical field for more than 38 years. He served as a general surgeon in different parts of Ethiopia, particularly in the Oromia regions. And he pursued his subspecialty in plastic reconstructive and hand surgeon where that I was also trained. That is the Bergen University and Vellore Medical College in collaboration with Addis Ababa University. Since 2007, that he also served that in alert as well as that Addis Ababa University Medical College. Dr. Ataklty has been that for me it might be difficult to introduce Dr. Ataklty. He served in different positions. One of the position is that he has been the previous president of Society of the General Society of Ethiopia, and he also still serving as that country representative for COSEXA, and he also that acts as that a coordinator for plastic surgery. Dr. Ataklty, he is a fellow for in COSEXA, and he's also a fellow of the American College of Surgeons. He served as advisors in different positions in Ministry of Health and also in the university. He has been also serving as a division head for plastic reconstructive and hand surgery in Addis Ababa University. One of the special that his interest is on humanity in medicines, art, as well as photography. And I'm really impressed that whenever that Dr. Ataklty is giving a lecture, my real interest is how he's really making the lecture really interesting, and that adding photographies, adding histories. His passion with histories that immense. Everybody knows him. Really, it's difficult that to introduce still Dr. Ataklty that. Now, today, he is going to still giving us that another lecture on digital technology, especially with medicines. He has been giving that humanities lectures on humanities, different that almost everybody has had the chance to attend these lectures in different international as well as national conferences. So he's known for on humanities, photographies, and to have that interesting lecture with him. Dr. Ataklty, the floor is open. You can go on.
Thank you so much. Am I audible? Can you hear me?
Yes, we can hear you.
Thanks so much for the nice introduction, these nice words that you have shared with us. Without taking much of your time, I will start sharing my slides. Today, we are going to discuss on digital technology in medicine, but I will give more emphasis on digital surgery. And it will be presented into three parts. I would like to give you a background and then some details. And at last, we'll have some moments for answering questions. So now I'm going to share with you my slides. Can you see my slides? Hello?
Yes, we can see.
Thank you so much. So the
You
title
can
of my
continue.
presentation is Digital Technology in Surgery.
Hello. Hello, Dr. Ataklty. Sorry, Dr. Ataklty is out. Let us wait until he reconnected again.
Sorry, I lost my connection. Can you hear me now?
Yes, we can hear you. You can continue.
Thank you so much. Can you see my slides?
Yes.
So, in summary, digital technologies revolutionize surgery by enhancing planning, precision, and patient outcome. Digital technology offers benefits like personal care, reduced complication, expanded surgical accesses, be it in the body or in inaccessible rural areas. Key advances are artificial intelligence, robotic surgery, augmented reality, virtual reality, and telemedicine. Challenge still remains, particularly in the low and middle-income country, pertaining to the cost, infrastructure, training, and also there is a growing ethical concern globally, which requires a cooperative and regulated approach, and we are trying to come up with the regulation. So this is a time when Reni was doing the first cardiac bypass surgery. As you can imagine, so many people are crumbling to see what is going on. This is an era where we didn't have so much technology to share several things in real time. So whenever we consider medicine, this is my belief that currently we are biomedical, we are focusing on the physiology and pathology, but I think there are two also important pillars that are so important to incorporate in the practice of medicine as art and science. So currently we are practicing science because we are focusing on the biomedical aspect of diseases. The psychological consequences and emotional and spiritual course are not included. So we have to move to biomedical, psychological, and cultural model, which has been proposed for the last 50 years. So digital health is information communication technology using computers, and you have data with systemic application. The patient would be empowered to make a decision. Health workers would have the chance also to participate closely with the patient on decision making in all the process of healthcare delivery. There is going to be also a strengthening resilience to diseases because of the ability to make a prognosis and also to make a preventative measures. It also improves ultimately the health and well-being of a society. So digital technology is a field of knowledge and practice. associated with the development and use of digital technology and ultimately creating e-health. That includes digital consumers. So we'll be digital consumers. So in this digital technology, you can think of Internet of Things. That means all the digital apparatus and devices are interconnected. We have artificial intelligence. We have cloud computing, and also the blockchain. The blockchain is a decentralized way of handling digital data in multiple layers, and also especially it goes from the past to the present. These digital technologies are including artificial intelligence, Internet of the Things. Now we have Internet of Medical Things, robotic surgery, blockchain, sensors, wearables. These are also, we are moving towards nanotechnology with including also various nano instruments circulating in the body, in the GI, in the blood vessels, and so on, to collect data, to deliver drugs that are tailored in terms of dosage for that particular person. Electronically recording, telemedicine, telesurgery, drones, particularly drones that are supplying medical equipment, blood for transfusion and so on to a very remote places. These are all included in digital technology. There are so many benefits. One of the benefits is currently with the traditional medical, the healthcare provision, we tend to see everybody as in one size fit all. Whatever we do, we think it works for everybody. But this is going to be changed into a personalized care. We'll have the capacity to predict the outcome of your treatment, whether this is malignancy, infectious disease, or chronic illnesses. With your intervention, you can predict the risk and the prognosis. And also with a continuous monitoring of the patient or the normal individuals in a society, you should be able to prevent and control various diseases. This technology would enable us also to make a data-driven decision, because we'll have a very strong data in our hands to make a decision, a rational decision. And also it helps us to deliver healthcare in a much better way, and also it improves surgery. This is a real-time communication, a real-time personalized monitoring and therapeutics that could be applied to each and every patient. There are so many economical advantages. One of the economical advantages is the expenditure. Of course, the initial capital investment is huge in terms of setting up the infrastructure, buying all the instruments and so on, taking people for training. But once you set up this, catastrophic out-of-pocket expenditure will be reduced. We'll have a reduced cost for early diagnosis. The early diagnosis will be made, and the amount that you spend for late diagnosis would be reduced. Also, we can have saving of our costs in terms of making a better clinical trials. Patients will be empowered because they will be getting adequate data in their hands. And also, to a certain extent, this is a very difficult concept, but it's a double-edged sword. But also the professionals now currently are overloaded with burnout and so on. With this technology, we might relieve them from excessive workload. So its impact can be categorized into 4 groups. One group is empowering patients and clinicians. The second is taking the care into a different normal system, extending the clinical care that you are giving in the hospitals, clinics, and so on to a different healthcare care system. Even you can move your care from patient to home. And ultimately, you would optimize the resources with a proper allocation and prioritization. So basically, this AI decision supporting system can be divided, either those that are tackling diagnostic supportive system or virtual care system. But as you can imagine, anything has a risk. One of the risks you can imagine is it's not superior than human diagnosis. This can be debatable, because as the artificial intelligence is getting advanced, there is a fear that it could be even superhuman. AI program may be difficult to understand because our AI literacy is not the same. And sometimes also we are ambitious, over-ambitious, and unrealistic as to the benefit of AI. There is an implementation issue. It could be related to the machine itself or to the end users and the technicians. There is a question of transparency and accountability, extremely cautious measures should be taken to avoid biases, because whatever we are feeding the system is determining the output. There is definitely a mistake that could be done by AI and various technologies. We need to have regulatory concern and the short challenge, like how many % of doctors would be out of their job in the coming few years? What kind of professionals will be replaced by AI? These are all social challenges. So the concern and challenge can be put into 4 categories. Either it's related to the machine itself, high technological rated risk, or user safety well-being, or it could be related to the data itself, like data privacy. Who's going to own the data? How could be shared? How could you share a very private health issue of a person to a wider range of receivers? And there is a question of transparency as a risk, and also the accountability. Who's going to be blamed if a machine that is running an AI or similar technology is in fault and something is happening? So this is all the ethical and safety issues that are coming these days pertaining to this technological application. So you need to have a principle and guideline. We have 6 principles and guidelines. One is inclusivity and equity. Everybody should benefit wherever that person could be, in the rural area, wherever. We need to create some kind of mechanism. And also the literacy should be equal. One of the issues is literacy. Technological literacy is not equal, so some people could be filtered out. There should be a good strategy in terms of application of transparency and explainability. The hardware accountability, responsibility is very important. And finally, also, these machines are going into the autonomous phases. They do the things by themselves. They do decide by their own learning processes. So what is this autonomy? How would you protect the autonomy? So these are all issues that are very important for us to understand. One thing that I would like to say is cross-border telesurgical procedures. These are procedures, long-standing, long-distance tele-procedures. Unfortunately, we have seen only 50 surgeries in the last 20 years. Vis-a-vis robot-assisted surgery, even in 2011, globally we had 1.2 million surgeries performed. This is because we have no standardized legal mechanism, and it's very difficult to have also a global regulatory framework that could address the technical, legal, and ethical barriers. This is a picture taken when a person from Central Florida operated a person in Angola. This is the first breakthrough long-distance surgery done in Africa. So this is my first part. If there is no question, I would proceed to the second part. Thanks so much. Shall I proceed?
Anybody that who wants to ask, you can ask. Otherwise, you can send them that on either on the chat box or on question and answers. Otherwise, if there is no one is, I don't think there is anybody who raised the hand.
Thank you so much. In that case, I will continue with the second part. This is we are going to dive on artificial intelligence. It is part of the digital technologies that we have. We have 4 components at least under the artificial intelligence: machine learning. These are learnings that are collecting data and learn, and we have different kinds of machine learning process. We'll come back into it. And we have also different artificial neural networks. And also deep into the sophisticated part of artificial intelligence, we have natural language process that picks the emotion and the wording of a patient. For example, when you are clerking a patient with the camera that is installed and the words that's collected, it will give you the whole picture of the conversations that you have with the patient, including the emotional reflection, the facial expressions, and so on, will be interpreted. And also that kind of data can be also related with the post-operative data collection. And lastly, we have the robotic surgery using robots. So artificial intelligence is defined as a computational technology that enables algorithm to learn from. And I want to emphasize this: to learn from, interpret, and produce prediction from, or autonomously act on clinical data. I'm talking about AI in medicine. So this could be, as I said before, operative robotics, machine learning, computer visions, augmented reality, natural language processing. So this is a highlight of what artificial intelligence looks like. It's like, the numbers that we have, whole number, natural number, rational number, and so on. You have the subsets. So artificial intelligence is a very big group comprising of machine learning, deep learning. These are big machines taking big data, and at times we don't know what is going on in between the input and output. We have the generative AI, including ChatGPT, for example, is generative AI. And also, again, we have the natural language processing. I would like to take you to some opinions about AI. Isaac Asimov, this is an author, a Russian-born, but one who was living in the US. He was writing a lot of science fictions. And, long time ago, in 1942, he came up with 3 laws of robotics. And his opinion was robots would not damage you. They would serve you. This is the 3 laws. But on the other side, Stephen Hawking was really skeptical about the final impact of AI on human being. So he said this could spell to the end of the human race. These 2 guys, Joshua and Max, they had interview in a Davos meeting in 2025 in Switzerland, and they said this machines could have a self-preserving instinct. So they might preserve themselves despite our control, despite our interest, and so on. So they insisted again on having a regulation by the government, having a system, a proper system. Otherwise, this is going to be out of the control of human beings. Yuval Harari, he wrote 5 books. The last books came in 2024. It's about artificial intelligence. And what he say is, if human being is smart, why is he self-destructive? So he is thinking that ultimately the human life would be full of dataism and colonization. Maybe we don't see democracy and other philosophies. We might be talking about dataism, a full control of data of human being. And what he's saying is, when you don't have the power to control, never give power. So you give power to a place where you can control the power. Otherwise, it is going to be an existential threat for the human civilization. And this this is a very versatile person from the investment. He said, in God we trust, all others must bring data, emphasizing the importance of data collection. So you collect data with machines, the machines learn, and ultimately they would be autonomous. They create content, they create whatever they like, and even they can be out of the control of human being. Maurice is the optimist. He's also from the business side. He's saying that, yeah, at the very beginning, we could have fear, but ultimately, as anything we adapt, we will adapt to AI. So what they say is AI and other technologies have advanced, they have matured, they have settled, they are near real time. They are in front of your door. You don't have any option. What you do is you accept and adopt. So these are some of the fears. These fears also we share, I share. Maybe we think that bad people using this technology would do bad things. We don't have equal understanding of the technology itself. There are some fearful products that could allow you to predict that these technologies are damaging, like the Terminator film by Schrödinger. Maybe including surgeons and other health professionals would think that they would be replaced. And finally, also, these machines could be super intelligent, more intelligent than human beings, and humans would be slaves. This would be masters. So computer was first designed by Charles long time ago, nearly 200 years back. And this was followed after an interruption of several decades by Matlock and Pitts. They came up with artificial neurons. These artificial neurons are mimicking the human neurons. And then Donald Hebb gave a weight of the neurons. Each and every neuron doesn't have equal weight in terms of the amount of data that it processes. So there are so many people who were writing even during that time, following even the book written by Asimov. This is by Edmund Berkeley, who wrote a book called The Giant Brain of Machine. He was talking about a machine that processes data. Alan Turing, you know about this guy. He's a very Very interesting guy, very intelligent guy. There is a movie about his life, The Imitation Game. So he came up with a Turing test, how to test also the capacity of a machine, how to learn. The same year, TESIS, the first computer system, was created by Claude Shannon. Joe McCarthy came with the word artificial intelligence. I think it was in 1965. Eliza was a computer, a therapist, and at that time it was very difficult. It was very difficult to differentiate whether Eliza was a human being or a machine. So indistinctive that people thought they were talking with a machine. Casemate followed, she came in the 80s. This is Casemate, a very ugly looking machine, but a very powerful machine that could learn deep. It had a multi-layer neural mechanisms, and it was a social robot. Tom Michel also wrote another book, The Machine Learning, and Siri came in 2011. And three guys, you know, also these guys, Musk, Elon Musk, Hawking, and Wozniak, they wrote paper to governments insisting that governments should control these technologies. Sophia, who had also a visit to us sometimes before, I think it was 3 years back, was created in Hong Kong with a Harrison robot, and she looked like a human being. The very interesting thing is what happened in 2017. In 2017, Facebook was doing a research, and the two chatbots were discussing. This was a research how the Facebook wanted to know to what extent they would discuss and they would interact. And at certain point, the Facebook researchers could not understand what they were talking. So these two chatbots create their own language. This was followed by creative, the GPT programs, the generative pre-trained transform. We have GPT, ChatGPT, and the various GPTs. So because of all these controversies, now people are going towards global regulation and ethics. AHRI, for example, is producing a guideline to control and regulate the use of AI and similar technologies in Ethiopia. So the generative AI, which is completely different from traditional AI, has a capacity to produce content. It can even produce a musical composition like Beethoven or Mozart. So now these technologies have matured. They have a good interoperability, availability, and they cover a large population. A proper lesson has been learned. They have become the pathway. We don't have any choice. They are being used by a lot of providers. The academic world is using, and particularly the investment group is highly utilizing this technology. So there is no way to run out. But you know, on the other side, there is some development, like how to really standardize these machines. Turbo framework is another one of the frameworks where you have testability, usability, reliability, beneficial, and operability is as a standard to decide that this process is acceptable for us. So initially we had traditional AI, which is rule-based. You feed certain information. You know the information that you are feeding. You are also deterministic, and you know the outcome. It doesn't create a content by itself. There is a predictability in terms of the outcome. So these are being used for fraud detection, for spam filters, and so on. And the kind of learning that traditional AI is using is the supervised way of AI reading. In contrast, when you have generative AI, which is an advanced one, it can produce content. And it's very difficult to really predict 100% what is the outcome. So they produce content and they are using deep learning. So they are using the non-supervised, and reinforcement type of learning will come back into it. So machine learning is basically an algorithm with statistical model. And we don't have explicit programs, particularly for those advanced ones. They are trying to identify patterns and they make prediction and decision. And now they are producing, they are going to be autonomous. We have reached to the level that they are autonomous in certain extent. So depending upon the kind of mechanism you use, these machines, their data learning process would be divided into three parts. The supervised learning pattern, where you label your input with an explicit program, and you expect an outcome which is predictable. But the two ones, the unsupervised learning is unsupervised learning. You give the data in a crude, and the machine filters out the data that it requires, and then it processes. There is no program. The reinforcement it's a trial and error method. The machine learns from its failure, from its outcome, from its rewards. Then it is a vicious cycle. And in this particular type of learning, you cannot have the chance to control, to know what is going on inside the machine itself. So you have three parts of the process. You have the input, you have the neural network structure, and you have the output. As the machine is so advancing, it's very difficult to understand neural network structure. And to understand that, you might require another application, another computer application to interpret. So this is what we call the black box type of neural network structure. So machine learning, AI, patient safety in surgery is very important in terms of providing surgical workflow analysis, autonomous performance of simple tasks, and also the ability to predict morbidity, mortality. And also nowadays, you can also assess the intraoperative technique of surgeons by taking data from their eye movement, from the movement of the muscles and the joints. You can assess, you can compete against the standard operating steps, and you can assess the dexterity and the skill level of the surgeon himself or herself. And now we have digital OR. So many things are in the academic environment, but definitely it will come into a normal procedure. So basically in spine surgery, for example, safety has been increased. They were able to predict the outcome. It was personalized care specific to that person, and also mitigating risk for that particular person, himself or herself. And also decision-making between patients and surgeons would be enhanced. This is a study done to investigate the effect of AI on spinal surgery. So machine learning, you have this data coming in, and you have the technique for modern computation, and then you try to explore unanswered questions, generate hypotheses. As the machine is advancing, even can create content, as I said before. So now comes to the machine itself. We have two kinds of machines, depending upon degree of learning. The deep learning and the conventional traditional learning. The deep learning is taking the black box model where you have complex mathematical function, and it captures intricate pattern, often with high accuracy. It predicts, it produces content. There is an opaque decision-making process because we fail to understand what is going on in between the input and output. It has several layers, and it's not linear. When it is not linear, you cannot predict. The traditional one is linear. The input is, you know what the input is, and also you know what's going on in the middle. So this kind of machines, they might require additional interpretation model because we don't know what is going on in between the input and output. The opposite would be applicable for white box model. So deep learning is a subset of machine learning that is interrelated units called artificial neural network with multiple layers to mimic the human brain by self-teaching while filtering information, self-teaching. So these neural networks are organized in terms of model neurons like the brain. And as I said before, they have different weights based on the amount of data the simple unit is processing. So they are using a simple mathematical algorithm called activation function. So we have different layers when the machine is so advanced, and it's very difficult to predict 100% the outcome of the result. So deep learning is completely different from the machine learning. I'm talking about traditional machine learning. These are some of the applications, like the graphic process unit is a deep learning process. Natural language processing is again a deep learning process. This is a convolution network. Neural network is also another example. On the other side, supportive vector machine, this could be also a simple AI learning. So natural language process is the ability to understand human language, not only the meaning, but also the structure, rules, and also the facial expression. So it goes into the sentiment, the meaning, the facial expressions will be picked by the camera. And this enables you to naturally appreciate what the person is talking about. It can detect adverse events in complications. So these machines, they are not working alone. I'm coming back to other technologies, but these technologies are, if you have, for example, digital or all these machines are working on the patient. Of course, there is definitely a limitation as to the application of AI. It's not a machine bullet, a magic bullet, and it hallucinates. Even, when you touch ChatGPT and you put some requests, it might say that this may not be 100% correct. There is a systemic bias depending upon the kind of data you feed. There could be bias. Basically, it's related to gender and racial bias. Interpretability is another challenge when you don't know what's going on in between. You need to have another interpretable application. That's another inability to determine causal relationship. This is not linear. When this is linear, you can have this causal relationship and the possibility of predicting the outcome. And also training data could be limited. They don't really have a true creativity, but if you allow me to guess, they will have this capacity to have a true creativity capacity. And it lacks to conceive, to understand entirely new ideas. There is also a problem with adaptability, and in terms of regulation and ethical concern, still we have a problem with privacy and security. This is what I have for part 2. May I continue, Dr. Abraham?
Yes, but before that, there was a question from Dr. Masfintola. His question is, how do we bring autonomy protection, particularly with what you're talking about, AI, that the part, it might be autonomous, it's beyond the human brain. Then how is going to be autonomy protection in this regard?
I think this is probably related to how you select your specific machine learning process to a very specific job. Then you can regulate. And you need to have also a trained technicians who can really run this. So you don't allow the machine to indefinitely continue working by itself until it is creating its own contents and so on, as the Facebook just decided to interrupt the research. So what you can do is, if, for example, you want to do digital surgery with this technology, what you can do is you don't give the full autonomy to the machine. Probably you add some human element into it. So this is the only way. Or you can trim the task to specific kind of task so that you can follow. Otherwise, this is a fear that a very powerful machine can take over and can do whatever it likes without you knowing it.
The other issue is that what is that your thought regarding that digital technology might replace human skills, and is that not going to be that a challenge? One is that. The other is like, for example, if you are going to use robotic surgery, the precision of that surgery that is assisted or completely done by a robot might be that superior to human being, and that might totally that avoid human beings that to be participating in surgery. Is there any fear regarding to that?
I think the digital technology, if I understand your question, is it's not avoidable. My feel is because of the pressure that we have from corporate companies. The corporate companies like the Google and so on, those big giant technologies are so powerful that it has now, it's like a snowball. It has already started going its movement. So it is impossible to really stop it. The only thing that we have is we should accommodate it like, for example, after 20 years, for example, if I'm not operating on any patient, I'm a young surgeon, may not physically operate a person with a big incision. What is the probable engagement of that young surgeon is to involve in the creation of the contents with artificial intelligence to advance surgery. So your role should be completely different in terms of adaptability. Regarding to the superiority, there is no doubt. You know, it's these machines, they have a lot of other advantage, like they have an overlap of image. Like if you are operating on the thigh or in the abdomen, you will have all the MRI scan really overlapping on your image. They can give you real-time intraoperative anatomy atlas on that particular patient. Even that particular patient could have a vascular anomaly or variation of anatomies. The variation of anatomies, you can see it. When we operate without this technology, we are taking the traditional medical school anatomy. We feel this is the course of that nerve or that artery or that GI, whatever we call it. But because of this, and because of the avoidance of tremor, because of the ability to go into deep spaces like intracranial or pelvic areas where you have difficulty, physical dexterity difficulty to go into that narrow space and see. These are all the advantages of this machine. So they are precise. They have a lot of inputs to increase their skills. So they are so far they are superior. Back to you.
Thank you. You can continue with that. Just there is no any.
Thanks so much. I'm
Anybody
now
wants?
going.
Okay. If there is
So
anybody wants to ask, but in the questions and answers, there is no questions that's asked in the box, so that you can continue.
thank you so much. I'm moving to the last part of my presentation. This is an extension of this technology, but very much related to robotic surgery, the application of robots in surgery. So it's been a long time since human being was seeking and dreaming of having a walking machine, non-human machine that moves. Ashoka in the Hindu mythology was dreaming a robot, and he wanted to battle with this giant robot. And subsequently, also during the Greek mythology, Homer wrote a good account of two individuals who want to create a giant moving warrior. The flying pigeon is a very documented exercise during the time of Pluto, that they created a moving pigeon, automated to fly. Even Aristotle and St. Thomas Aquinas, Descartes were talking about the possibility of having a thing that moves like animals and like human being. But the word robots came from Czech word coined by Karl Kapik at the first quarter of 20th century. Its literal meaning is forced labor. Then came as a very beginning of 20th century, I think 91 and 1910, was the earlier introduction of laparoscopic surgery by two individuals in two different places. Nashamiro, he built the first robots in 1929. Can you imagine this? Long time ago. Smith and Boyles, they created the digital image, the image that we are using in our laptop, in our digital cameras and mobiles. They were discovered, they were developed long time ago, and it has been an input to the development of robotics, because these robotics also are using photographic images for their function. Puma, this was the first robot used for taking biopsy on a patient with astrocytoma. It's a needle biopsy, but they used this machine in 1985. Robodoc was used also in 1992 for a total hip replacement. This machine was able to dictate the surgeons how to make a proper, precise osteotomy to put the total hip replacement instrument. Three guys are so important for the development of digital surgery. Scott Fisher from NASA, Phil Green, an engineer, and his friend was Joseph Rosen, a plastic surgeon. They developed telesurgery. And in 1987, they were able to operate a patient who was injured on the hand with injury to the vascular system and the nerves. So they were able to operate this patient from distance. And another adventure was the possibility of John Bowersock from, he was able to do intestinal anastomosis from a remote place. Once we had the Puma of different editions, then we had the ASOP 1000, which was followed by Zeus. And finally, we ended up having the Da Vinci technology or Da Vinci devices coming with different edition. So these processes were supported by computer motion and scientific surgical companies. To your surprise, long time ago in the 70s also, William Intoven, the cardiologist, he was able to print an EKG using a normal telephone wire with a distance of 1.5 kilometers. He was 1.5 kilometers away from the patient. With using simple telewires, he was able to print the EKG of the patient 1.5 kilometers away from where this doctor was practicing. So these were some of the products. Now we have the next generation robotic surgery ecosystem. So we surgeons, particularly young surgeons, should be able to go into this ecosystem. This is inevitable. Surgery is going to be revolutionized. We don't probably continue operating with big incisions and so on. So this next generation robotic surgical ecosystem is comprised of robotics, augmented reality, virtual reality, and artificial intelligence. And I think they have now a mixed reality, which is a combination of augmented reality and virtual reality, enabling the surgeon to interact. So augmented reality or virtual reality, you may have some difficulty to interact, particularly if you are using augmented reality. You are operating on digital system, use the image of the patient, the CT, MR, and so on coming in. So it is unidirectional. The machine is giving you input. At the very beginning, people were not able to go back and ask the augmenting reality system to interact. But now you can mix this one. Even the adverse reality is coming, which is an advanced one, where you can have a good input of all the technologies. And the most important thing is you can interact. So surgery has progressed from a prototype master-slave system to autonomous. 5G is being used with a short latency period. Now they have achieved, the Chinese achieved a latency period of 60 microseconds. So latency is very important in this technology, because if you have a very slow connection, the machine would go into error and make a very big mistake. So this is how we are moving. So basically, this is a stereotypic robotic surgery where we have a master far away. It could be a short distance far away or a long distance far away. A short distance, it could be in the room, but the system, the console is differently situated from the patient. You have the arms and so on, the robots on the patient, and you are in the console that is situated in the same room or in the vicinity. It is a short distance telesurgery. But you can have the intercontinental type of surgery where we have the masters in Europe operating somebody in Beijing. So one of the surgeries done years back was a person who was operated in Beijing by a surgeon in Italy. So this is a master-slave system where we have, as you can see, a feedback that is communicating with the master and the slave. So this is one of the questions I was asked before. This is how we are moving, and probably this could answer your question. You have a full autonomy. This is what we do now. Surgeons have full autonomy. The supportive staff is full. We don't have robots. This goes on to the level of 1. The level of 1 is this is a reverse. No autonomy is, you completely control everything. Supportive staff is 100%. The supportive staff all the way to the autonomy is fully engaged. So as you go up and gives autonomy, a high autonomy, what will happen is the surgeon would be knocked out. So probably stopping at high autonomy is the best for your question. You stop at high or conditional autonomy or high autonomy. If you give a full autonomy, these machines can create contents, can be uncontrollable. So the answer is keep the machine at the level of conditional autonomy or high autonomy. Clinical outcome and benefits of robotic surgery is undeniable, as you, Dr. Abraham, asked me. It improves the outcome of patient, it reduces complication, recovery time is short. Of course, operating time is long, with a very different learning curve. Cost is effective. I'm not talking about the initial capital investment. The surgeon's experience and training would be improved. There are so many technical advantages, as I said before: visualization, dexterity, precision. Working in difficult areas, like you want to operate a person in the rural area, in the combat zones and so on. So these are all advantages, and the recent ones are coming with a large degree of freedom. Like you take the wrist is moving maybe into 7 types of motion. So this is what we call degree of freedom. When you are advancing, when the machine is advancing, the degree of freedom is increasing in number. And also the port, instead of having 4 ports, you will have 3 ports, and now the aim is to have only 1 port, so that the recovery time of the patient would be very much shortened. Advantage: we can do minimal invasive surgery with precision and stability. It's safe, it's efficient, it can be done in remote areas. The limitations is cost and accessibility. This is particularly important for the third world. The other problem that technology could not really tackle is haptic feedback. If you palpate a liver palpation, the feeling that you have on your hand will be completely different when you touch the intestine. So this is one of the shortcomings of the surgical robots. You cannot feel the haptic, the consistency. Insufficient intelligence: this is basically not related to the machine, but related to the operators. Some of them are bulky, and for the training, for the surgeons, this is a problem. They can have a learning curve, which is challenging, particularly in older people like me. Technical issues, safety concerns, and also, do you accept, you yourself, one of us, to be operated by a machine in the absence of a human being, or a human being that is far away from us, thousands of kilometers away? So patient's acceptance is also one of the limitations. There are emerging frontiers. One of the frontiers is to make them small, to integrate more the artificial intelligence and machine learning, to promote telesurgery, particularly for remote areas. The fourth and very interesting is the nanorobotic in surgery. These are small machines that could probably navigate in the blood vessels and probably eat in the plug, the atherosclerotic plug, for example. Or you can deliver drugs and so on. And also improving the haptic feedback. And sensory augmentation is another thing. And genomic study has been introduced, so these machines would know before they operate the patient, they know the genome. They know the genetic predisposition of this person to a particular complication or a particular disease process. There is a good collaboration between surgeon and robots as the situation is advancing. I think people are working more on regulation than ethical consideration. This is going to give us a good ethical framework to practice this digital technology in surgery. So digital surgery is the use of technology for enhancement of preoperative planning. You see the whole spectrum. This technology is not only in the operation theater. It starts with a preoperative plan. It starts with the first encounter of the surgeon with the patient, with the natural language processing, with all the other gadgets, with the image, the lab data, and so on. These are all incorporated. Then comes the surgical performance, and this is just to reduce harm. Medical error has been dramatically reduced, and outcome has been improved. So this is the use of technology for the purpose of both preoperative, intraoperative, and postoperative processes. So advantage is we can navigate and visualize digitally. will be precise and will be less invasive. The distraction and cognitive load, when you operate like a patient with neck mass, who's so close to the carotid, you are bombarded with cognitive loads. So this cognitive load should be reduced for the surgeon. The surgeon will be relaxed. And hence, overall, the error that you create, error is maybe cannot be avoided, but it will be very much reduced. There is going to be a good communication. From the outset, this process would give information to the patient so that the patient would have a rational decision. So the journey between the surgeon and the patient is smooth, and it's going to be a common journey. You will be smarter, safer, and you give personalized surgery if you are using this technology in surgery. Robotic surgery, it removes the surgeon's tremor, and also it avoids unnecessary movement. We surgeons, we don't know. I'm subconsciously, I don't know if somebody could take us our videos when we are operating. I would feel that unknowingly we do some movements. You kick your assistant. You really, you are not economized in terms of movement. So this movement would be very much precise and reduced. Structures will be very much utilized. You can access inaccessible areas. This is particularly true for pelvic areas, spines, and also intracranial spaces. 3D visualization of the operative field. The machine will give you the anatomy of that particular individual, taking sample from the MRI and CT and so on of that particular part of the body would be transformed into a 3D high definition visualization. So you are operating actually on that particular patient. The anatomical variation. What is deep inside, which is not on the surface. So it really reduces the human error prevalence. Challenge like any digital technology, this robotic surgery is also has a problem with data. Who is going to own the data? How to share the data is very important. Patients are giving you so many informations that are confidential. Public is trusting you. So how would you keep this privacy? How would you keep this from being hijacked, from spoiled, from destruction and so on? And also consent. How would you consent about the possibility of injury when the machine is operating? Are you going to be is the surgery responsible or the machine? So we need to have law, we need to have a framework. So there are a lot of litigation and liability. And also the other thing is the push of the corporate business. The corporate business is so powerful in terms of designing new technologies and also introducing. So it's very difficult to challenge this pressure. So we have moved from the past to the future. The future is going to be digital surgery with autonomous machines. So as I said before, on the right side, for me, is the machine that could detect signals from the eye movement, from the muscles. You have EMG sensors on the surgeon himself. And then you can also see how the person is following a standard steps for doing the surgery. Like you do appendectomy, there are steps. Is that particular surgeon following? So in a way, this technology is coming also to assess us if we are really skipping some steps during surgery. Also, if you injure, a preventable injury also can be detected by this machine. Preoperatively, you can do so many things like early accurate diagnosis. You can predict risk, and you can also, by taking a monitoring of the public, as you already said, data. You take data from genome analysis, continuous real-time data on hormones, on sugar levels, and so continuously. This is going to be, you will have a huge data that could enable you in a positive way to assess the emergency of new diseases or the magnitude of existing diseases. The other side is you are collecting data from people, and you can use it for some other purposes. This is a challenge. Intraoperatively, you will have good guidance. You are operating with robots, and also the surgical training so far is on patients. This is going to be stopped, and you will have virtual reality for a surgical training. This is as if you don't have haptic feedback, but it's as if you are operating on the patient. You have the anatomy, you have everything. You can do it at home. You can do it on the street, anywhere, wherever you like. And also you can do it several times. So you can train yourself before coming to operating a patient. Post-operatively, you can have a follow-up. The patient is not with you. The patient is far away at home. Even with daycare surgery, the patient is going home. But you can follow. And also, at the very beginning, you are collecting data with the natural language processing and so on. So you can predict if, for example, a patient is going to have anastomotic leak during colonic surgery. So that far you can go and you can apply this technology. This is a famous breakthrough. The Lindbergh was a pilot who crossed the Atlantic Ocean alone. It was, I think, in the beginning of 20th century, the first quarter of 20th century. So this surgery was performed, I think, in 1985, but they gave it the name of Lindbergh because of the distance he traveled. So this surgery was done from New York to Strasbourg in France on a 60-year-old patient, and they used the ZUS system. The patient was discharged in 48 hours. There was no complication. Surgery took about 45 minutes. They did cholecystectomy. Another surgery that I talked about was the surgery was done from Rome to Beijing using the 5G. And very surprisingly, the latency of communication was about 70 microsecond. So we are moving from a preoperative, postoperative teleconsultation to a new research, but before we have the telesurgery. So this is a spectrum from real-time communication. The person is in a cafe with a mobile apparatus. You can see the data of the person, communicate with that particular person. There's a real-time communication with this wearable technologies. You can even have minute to minute, second to second sugar level of a patient. So this is we are forwarding, and telemedicine is really emerging into telesurgery, and we are creating a digital health. But there are challenges in terms of policy. It's a huge investment. It requires infrastructure. Still, the public should accept. So a massive awareness creation program should be there. There should be a legal framework. Training is required, and also the AI should advance. This is particularly the advancement of the technology itself. So as I said before, one of the challenges during digital surgery is latency. Latency is when connection is slow between two messages or two signals, you will have a wider time. Like, for example, it's not acceptable to have 150 microsecond in between signals, because if you have that latency, the machine cannot properly work. The other challenge is what's happening in low and middle income country. This is probably because of the technology itself, our literacy levels, public acceptance, and also we have so many other priorities to deal with. Financial cost is enormous. Again and again, I'm talking about regulatory and legal components. And these days, the most frightening situation is how to keep your data secured. So cybersecurity with no cyber attack and data privacy would limit the use of digital surgery abundantly everywhere. So telesurgery, it has a master sense, like I said before. You will have a reciprocation of inputs, either visual or other inputs. So the master and slave will have a real-time interactive both-way communications. So as I said before, it could be a short distance telesurgery or a long distance telesurgery. Visual reality is a creative, full immersive stimulation, a simulation of environment or a virtual space. You just put on this on your head, then you see as if you have the anatomy of the patient in front of you. Or for that matter, anything that is scanned could be incorporated. The augmented reality is a completely different thing. This is overlapping of images into the existing digital system, so that interoperating, while you operate, you will have the chance to see, like you are operating, for example, a periampullary tumor, and you are still in the stomach, maybe you are in the abdominal wall. Still, you can see with the image and so on, you can see what you would encounter in terms of the various important structures, be it the common bile duct and so on. You will be ready because it is giving you a virtual 3D anatomy. And it's a real time. It's a real time. The patient is moving, is changing. So they are complementary. The virtual reality and augmented reality are complementary. Basically, virtual reality is being used for preparation and planning. It's good for training. Unfortunately, augmented reality doesn't have interaction. It gives you the image, it gives you the 3D image and so on, but you cannot interact. You cannot ask the process to do something. You don't have that kind of communication. So to combat these problems, they have added the emergency of virtual reality and augmented reality in both. They are merged, giving you a mixed reality where you have interaction between data that you have and yourself and the team. So this is one of the products. HoloLens is something that you put on your head. It gives you the mixed reality. So the precision is unmatched. Better outcome, short surgical anesthesia time, fewer complications, fewer human errors, more patient operated, faster recovery times. The advantage if you are incorporating virtual augmented reality in your digital surgery process. If you compare the two, the virtual reality has no risk. You are not operating on a patient. There is no patient. You can make mistakes. That's why it's very nice for training. Also, you can try, you can attempt new techniques. So you'll be confident. You will have good preparedness before going into the patient to be assisted on surgery. Augmented reality, you can navigate the body like a smart glass as you operate, analogous to GPS. You can call it. It's a kind of GPS. Mixed reality combines the advantage of both of them, as I said before. So virtual reality is more for planning, for training, and a good communication with the patient. So maybe mixed reality is typically higher fidelity stimulation. It's a real thing you feel, and it's trying to give you haptic feedback. Can be used in remote surgery. It can incorporate record objective performance of the patient, the person, the surgeon, the person can be assessed with eye tracking and tracking of the muscles with EMG. There is a faster learning curve, can be combined with physical modeling for higher fidelity of stimulation. But unfortunately, it cannot replace human being. I doubt this. I really doubt it. Also may present a false security to the users. It's heavy, it's expensive, and also you could have inattentive blindness. So you will be out. You don't focus on what is going on because you just will be driven out from the process itself. Occasionally, it's difficult to register images. Minimal access surgery, it reduces invasiveness. Blood loss is very much reduced. Post-operative pain is less. You have short operative hospital stay, and also finally, there is a fast recovery. The landscape, it enhances access to remote or difficult areas. It reduces the travel of patients because the patients will be operated around their vicinity. It addresses surgical shortage, surgeons from any part of the world can operate. And the most important thing is you'll have a real-time collaboration. It's an ongoing conversation that you have with the component of the system. And you can also do remote surgical training. In low middle income country, it's still advantageous in terms of enhancing access to specialized care because the one who's doing the service could be somewhere else. It's just a matter of setting the physical structure. It improves also the training and capacity building. This is also, again, with a remote surgical training assistance. Cost will be reduced. I'm not talking about the initial capital investment. Once you have that, the cost will be very much reduced. And also, as we discussed, digital surgery anywhere else, you will have also a good outcome on the patients. This is particularly true for fast recovery time, less pain, and reduced surgical site infection. But there is a challenge. The first challenge is infrastructure and connectivity. As you can see, at the very beginning of my presentation, I had difficulty to get a good connection, and for a couple of minutes, I was away from your face. So this challenge is also relevant when it comes to digital technology in these countries. Digital divide is, this is digital literacy. So the amount of understanding, affordability, and so on is not equal. So there are some privileged individuals with affordability to access the advantage, but others, even if they have the money and other resources, they may not have the digital literacy. So this is a challenge. And also the inability to really secure the data and also to make it confidential is another challenge. Training and skill development requires some time. Still, we have not developed our ethical consideration. But luckily, recently, I heard the good news from AHRI that they are coming up with a guideline to draft ethical and legal concerns and considerations in the use of AI. I'm not sure if it is encompassing AI in surgery. Lastly, lack of standardization and regulation is another challenge. So in summary, digital technology is revolutionizing surgery through enhancing planning, precision, and patient outcome. There are key advancements that are really coined with AI development, robotic surgery. We have the mixed reality telemedicine. These technologies offer benefits like personalized care, reduced complication, and expanded surgical accesses. Challenge remains to be in relation to cost, infrastructure, training, and ethical considerations. And lastly, it requires a collaborative and regulated approach to adopt this technology, be it in low resource country or in advanced part of the world. So these are my references. This is one of my paintings. This is Jinja, 80 kilometers away from Kampala, and it says the origin of Nile. I modified it into the origin of White Nile. Thank you so much for listening. Thank you. Bye.
Thank you very much, Dr. Ataklty. That was an interesting lecture talk. I had the chance to learn a lot of things. Before going to that allow for audience to ask, I just want to read some questions on question and answer boxes. The first one is from Dr. Masfin Tola. What was his concern is that usually robots, they do have that a coarse and slow movement, which is not expected in like for which expect fine skills in surgeons, comparing to the fine skills of surgeons, that robots are coarse and slow movements. So how do you address this one in robotic surgery? The other issue is that usually because the robots are slow, there is a concern of anesthetic time, which is critical in surgery. So how do you see it that having the robots to take longer time? And how are you going to balance the safety of this slow and coarse movement? That's one. The other issue is that from Dr. Masfin is that is a suggestion or an opinion. What he wrote is that I wish the master slaves nomenclature of two remote machines be changed by other names at this stage. I don't know. You can give us your opinion. The second question is that what will be the safe of us, the fate of us, especially African surgeons or surgeons working in the low and middle income countries or in sub-Saharan countries? That is what is written on the questions and answer box. The other issue I just want to add is that taking or the challenges like, for example, policy, infrastructure, finance. When do you think that this technology is going to be introduced in Africa, particularly in Ethiopia? And the other issue is that from the surgical fields, which part of surgical field do you think that is going to be forerunning that to introduce this digital technology? Like, is it going to be orthopedics, general surgery, plastic surgery, neurosurgery? Which field of surgical fields do you think that's going to be the first to get the chance to introduce digital technology. Thank you.
Thank you so much. Just to reflect on, to just share with you my ideas. Let me start with the kind of procedures or the kind of surgical disciplines that could benefit very much. I guess the human body is navigatable, but historically, this is the revolution is very much related to neurosurgery and laparoscopic surgery. So I would consider that these are the two areas that would advance. But taking the advancement of the technology itself, the human body is navigatable. It's a matter of adjusting it. And the second point is, when do you have this? You know, Abraham, during our time, when we talk of laparoscopic surgery, nobody was really listening. I mean, including us. We thought it will never come. And people were not ready even for that development. But as you can see, now it's flourishing. In a very short period of time, you can have all the technology. So the introduction, the rate of introduction of this the technologies has been exponential. So shorter time is needed to introduce. So I guess because even from policy direction, the Ministry of Health is talking about AI. By and large, the government has opened Institute of AI for AI training and so on. This all indicates that countries are trying to prepare themselves to accept this inevitable, near real phenomenon. It's knocking your door. So it must be coming. What will be the fate of us? I think this is probably, I'll see it from different angle. I don't think we'll be knocked out. Of course, there is a possibility that we could be replaced. We could have also difficult to get jobs. But on the other side, adaptability. How would you, because if you're using digital surgery, most likely there are surgeons at the background. So what are the opportunities that you have to fit yourself in the process? Maybe your role may not be to take a knife and operate. So this kind of shift in thinking is required. So there are changes. That change, you have to manage them. Actually, you have to bring future to the present, because this is inevitable. After 20 years, 25 years, surgery will be different. So predict what kind of surgery you will have, and then to keep yourself in that process, to keep yourself on the train. What are the opportunities that you have? So this would determine whether you have the possibility to keep yourself in the market or to do something else. The master's slave will be changed. The terminology will be changed when we subdue ourselves to the machine. When we subdue, we give up, and the machine is autonomous. There is no, probably between the machines, there could be masters and slave. I'm talking now about the interaction of human being with a machine. The human being is, to a certain extent, has some involvement, a master, and then the machine is operating. But the machine, when it's autonomous, most likely we have to find out other terminology or the same terminology, but the master slave would be machine. Operating time is long. Definitely for prostatectomy, it might take about 6 hours. But one important thing is the perioperative care, the preparation of the patient. We are talking about advanced perioperative care with good anesthesia, drugs, with good selection of patients, and also time management. That's number one. This is calculated against the other advantage: the hospital stay, the rapid recovery, the pain control, and also the ability to follow the patient in a remote way, and also bringing the care from hospital to home environment. These are all advantages. They have a psychological, a medical, and economical advantage. You have to equate this with the surgery that takes 6 to 8 hours versus you operate the prostate in 1.5 hours. The patient is staying in the hospital 5 days with irrigation and so on. And then the pain and all this, complications that we see with traditional surgery should be equated ultimately. Somebody should sit and see the advantage, disadvantage, and currently the consensus that people are sharing with us is the balance is tilting towards having long surgery with advantage of rapid recovery. People go home or go to the working place. They will be economically active in a short period of time. Pain is reduced, and other advantage. Above all, the prevalence of medical errors would be reduced. Medical errors is among the 5 commonest cause of admission and death in the developed world. You can imagine how many errors are happening globally. So all this would be equated. And the other advantage is you can't really separate the digital surgery from overall the digital technology in medicine. The genome analysis, the surveys that you do, the data that you collect, all this should be given into account because the digital surgery is part and parcel of the digital ecosystem.
Thank you. There is also another question from Dr. Ataklty. His concern is about creativity. How do you believe that AI without having new idea?
Currently, there is a limitation in terms of heavy involvement in creativity by these machines. But if I am allowed to predict, this is a very temporary issue. As the machines are so sophisticated, these are huge machines. Sometimes they would be put into the sea, the base of the ocean, and so on for cooling. In fact, people are worried now that they might consume a lot of energy, and there could be a global energy shortage because they consume a lot of energy. So these are big machines, and as they have this capacity of learning, doing errors, correcting their learning, and also running away from the oversee of human, they could have that chance of bringing creativity because even now they are producing content. But back to this effect on us, I think we will live longer, we will be healthier, but we'll have brain age. So as these machines are really giving us so many comfort, shortcut and so on, our brain, which should be considered like the muscle, will be atrophied. So this is one of the challenge. The current fear is the brain age. The brain age and various degenerative diseases that could be linked with the inability to use the brain because these technologies will replace so many. Like you don't have to write a novel; they could write a novel. You don't have to compose a music; they can compose a music for you. So they do so many things, and also at home or in the working place, they can do so many physical things. So we are out actually. This is one of the fear, the disaster people are thinking. I think somebody asked me about the accuracy. So accuracy, again, we are talking about different levels of machines, different levels of, this is a spectrum. When you talk of traditional AI and you go to the generative AI, the advanced ones, this is a spectrum. The more you polarize to the generative AI, the degree of hallucination and error is very much minimized because they are using heavy data, which enables them to generalize. So this is a spectrum. You are using the previous editions, small ones, and so on. They are traditional. Most likely they hallucinate. They make errors and so on, like they did errors in some places as we follow the news. They do mistakes. But you are advancing towards the generative AI, these modern ones, the degree of error is very minimal. But one thing that you have to understand is the world is not free of error. For example, the aviation technology is the safest transport method, but it's not without incident. So we have to look into that kind of things. Of course, so many things are singular, they have singularity and linearity. Like when it's happening to you, it's 100%. So if I'm operated by a machine and the machine has gone wrong and I'm having some difficulties, for me, it's 100%. But overall, how many incidents would happen globally in a fixed period of time could be minimal with the advanced technology.
Thank you very much, Dr. Ataklty. There are also another more questions. One of the question is that regarding to the medical legal issues, who will take the responsibility in case of possible machine errors or malfunction? That's one. The second is that AI more mistakes, how to believe can make more mistakes, and how to believe that. How do you believe that whether that's a mistake or a real that um, true thing that what is produced from the AI?
Yeah. The first question, please.
The first question is regarding to medical legal issues.
The
Because
medical legal
a machine
issues,
can be malfunction, so who is going to be responsible?
the machine is not accountable. The machine is not
So
accountable. When you are
okay,
having some degree of autonomy, up to the level of high autonomy, a complete autonomy to the machine given, it requires a legal framework. Because you cannot take the machine to the court. But so this is the current practices. You have a framework, and still people are dealing in the umbrella of having a certain degree of autonomy in the process. The second question is about
regarding that, because AI has that full of mistakes. So how are you going to believe that? How to
again,
believe? Because
yeah, again, probably what I could say is you should run away from giving full autonomy. If you are giving it a full autonomy, you
the
cannot
other
predict.
issue,
Please.
okay, the other issues from one of the anonymous attendee, what I think he wrote in even in Amharic that ስለዚህ የሰው ልጅ በገዛ እጁ እየጠፋ አይደለም ምን ይመስሎታል ነው?
I think this is debatable now. It's debatable because even those ones, the scientists designing the AI and so on, are insisting on regulating AI. So it's up to us to be able to regulate it. If we are not regulating it, as you predict, will be washed away. And I recommend the book written by Yuval Harari. He has this Sapiens, Homo Deus, 21 mistakes in 21st century, and also he has Nexus talking about information data. So what he's saying is, if we are smart, if human being is smart, why is he self-destructive? And he's talking about data. He's talking about the new technology. The new technology he believes is destructive. He might have this polarized stand pertaining to his opinion about AI. So if you ask me my opinion, I'm not an expert on digital technology. I'm just a surgeon. I'm just fascinated to explore certain things. But from my understanding, from what I heard, most likely it is disastrous.
Well, the last one is that an opinion from Dr. Ahmeddin Alami that more data is utilized for machine learning when we are approaching to the reality, because machine learning needs around 100,000 data sets. So the more data feed that the accuracy is going to be high. That is what I think I understood from what he wrote. So the more data it is utilized for machine learning, we are approaching to the reality, because that needs at least that 100,000 data sets. There is no more questions in question and answer box. if anybody wants to talk, the floor is open. That if you want to ask Dr. Ataklty. If not, I'm really honored to moderate this interesting talk where that more than 100 participants that attended. Almost I saw about 108 attendees were there. Thank you very much, Dr. Ataklty. Hope we are going to have more type of lectures in the future. If we don't have anything, I will give back the floor to Dr. Mulugeta. Back to Dr. Mulugeta. Thank you very much.
Probably a few words. I would like to thank for your patience for listening to me. Perhaps it is a little bit long presentation, so I would like also to recognize your patience and also your active participation. I would have liked to have more time for question and answer, but time would limit us. But I would like to thank the Ethiopian Medical Association for inviting me. I would like to thank Dr. Abraham, my friend, for the introduction and leading the seminar, and also above all the audiences for their patience, for their participation, and showing their interests. Thank you so much.
Thank you very much. But anybody who wants to contact Dr. Ataklty, you can get him through his WhatsApp number 0911 23 70 51. You can call him directly, or you can write through the WhatsApp so that you can discuss more. Thank you very much.
Thank you, Dr. Ataklty and Dr. Abraham, for a wonderful presentation. Thank you all participants for your active participation and patience. I hope you all participants learn additional knowledge on how to use digital technology to leverage surgery, as currently digitization needs more attention in developing countries regarding infrastructure and coping with technologies. Additionally, I invite all of you to join our main annual medical conference and international health exhibition, which will be commenced on March 27 to 28 at Hilton Hotel, Addis Ababa. Finally, those who want CU certification, you can get post-session queues on chat box and enjoy it. Thank you.
Thanks so much.